Good afternoon, dear colleagues. I would like to give you a very warm welcome on today's Euro webinar organized by the European School of Urology. Our today's title is Local Intravesical Treatment of IC BPS, the Present and the Future. I am Béla Köves from Budapest, Hungary, and I will moderate today's webinar. We have two very expert lecturers in the panel, Dr. Dick Janssen from the Nijmegen, the Netherlands, and Dr. Sándor Lovász from Budapest, Hungary. They are both experts in the scientific research area and also in the clinical management area of Bladder Pain Syndrome. So we have a very good expert panel. In the first lecture, we will focus more on preclinical evidence, and Dr. Lovász will give a more detailed summary about optimal practical management strategies for patients with BPS. So we can talk both about preclinical and clinical aspects. I would like to ask Dr. Lovász to give your presentation about instillation therapy.
So, I would like to speak a little bit more in detail about the local intravesical instillation therapy. First, I should declare my conflict, as I am a co-founder and the medical director of the UroSystem Limited. This is a small company which was founded for research and development, marketing of different methods, tools and devices, all for interstitial cystitis. Here, a short summary of Campbell's Walsh urology about the Etiopathology. I don't want to go in details. I just would like to show you some important things. Maybe the first point is a bladder insult, whatever the cause can be. This damages the bladder epithelium, and a leaky urothelium comes, which on one side leads to mast cell activation and histamine production with all conducting problems. And the progressive bladder injury comes from this, which gives a positive feedback to the leaky urothelium. And this means there is a vicious circle. If it remains so, then the progressive disease comes and the progressive worsening of the situation. That's why the main goal of intravesical therapy is to yes. I don't know if you see it well. This is my side. The main goal is to reduce the chronic chemical irritation of the bladder wall, to reduce or stop the leakage of the mucosa, to reconvert the bacterial inflammation, to substitute the missing compounds of the gag layer, and to stimulate the own production of the gag layer. The questions and the answers can be found under these 4 points: why, what, when, and how to use. The first point is why. The intravesical drug therapy has a lot of challenges. There is just a short duration of action because the patients cannot take for a long time inside the bladder the medication. There is a lack of permeability of the urothelium, as we just recently heard. And there is a lack of bladder uptake of the drugs. But on the other side, there are advantages of the intravesical therapy. High local drug concentration can be reached, low blood level, therefore there is no systemic side effect, and no efficacy reduction due to metabolism. Intravesical instillation therapy in combination with oral medication substitution proved to be one of the most efficacious and maybe the most quick causal treatment form, even over longer time. There's a correlation between the invasivity and the efficiency of the treatment options. Therefore, the AOA guideline and many other guidelines also recommend to go ahead from the non-invasive or less invasive treatment forms to the more invasive ones. That's quite logical. Basically theoretical, it can be agreed. The less invasive is at the same time the less effective form as well. And the ineffective treatments are the most expensive ones because they cost a lot, they take a lot of time, and wasting time is money, and therefore the ineffective treatment is not the best one. Let's start the treatment with the most efficacious causal treatment, and this is the bladder instillation therapy. What we give. The instilled drug solution, the so-called cocktails, varies a lot among countries. We use these agents as it were already detailed in the previous lecture, DMSO, lidocaine, heparinoids, and the so-called gag layer compounds. Just a few words about dimethyl sulfoxide. It has a lot of advantages in urology as a topical analgesic effect, inhibits mast cells, anti-inflammatory effect, relaxes the detrusor muscle, and stimulates the nitric oxide release. But the side effect is also expressed very hard garlic breath over 2 days, and it makes pain, irritation on the site of the installation. The lidocaine, just in 2% concentration is effective. Less than 2% has no local effect. It anesthetizes the bladder efferent nerves, reduces urinary tract pain, but enhancing the retention time of the drug solution in the bladder is very advantageous. We use buffered lidocaine for it based on the publication of Parsons, who proved it is much more effective than the lidocaine alone or versus placebo. It shows 3 times more patients can be found who observed improvement, the general response assessment, for 10 days than in a placebo group. So the effect is not very long lasting, but still it is one of the best symptomatic component of the cocktails. What we give? Heparin plus alkalized lidocaine. This combination proved also to show slight improvement, or as the publication says, better on global response assessment. But it is well tolerated for non-Hanner lesion type ICs. The local gag layer replenishment causes chondroitin sulfate, as we heard, hyaluronic acid, although it is not directly in the gag layer, but it plays a very important role, as it was detailed previously, heparinoid compounds, and also as local treatment, the pentazine polysulfate is also an option. It has no side effects, but the clinical experiences are quite limited with it. These compounds are mostly used as bladder cocktails. Different compounds and combinations are used in different countries. There's a big difference between US and Europe. As we don't know which gag layer compound is really missing individually in individual cases, therefore it is quite logical, and the clinical experiences prove that the combination of the components gives a much higher response rate than any monotherapy of these. So the intravesical gag installations were evaluated in a very nice publication by Madersbacher. And although these gag layer compounds are widely used in Europe, they were never approved for use in the USA. There were large trials which failed to show the efficacy of hyaluronic acid both in small or larger dose. And the chondroitin sulfate also failed in large phase 2b efficacy trial. And the heparin and pentosan polysulfate was never studied in large randomized clinical trials. Therefore, the conclusion is that large-scale randomized clinical trials are urgently needed. When to give? The intravesical instillation therapy is generally accepted that it is given first weekly, then biweekly, and then continued by individually tailored frequency depending on the reaction of the patient. How can we really know what the patient reaction is? Here you see the data input signs. We always ask patients to fix at the beginning, before the beginning of the treatment, all quantitatively measurable parameters. This means quality of life questionnaires, pain questionnaire, and urinary diary data. And these are regularly repeated. And based on these regularly repeated data, we can make such diagrams. Here you see, based on our database, automatically produced diagrams. Here, for example, an already recent score as it was before the treatment, and it shows optically very clearly that the patient became completely symptom-free over a longer period. Or on the second curve, here you see that after the instillation, the mean voided volume, the capacity of the bladder, slowly grows over 2 years long, till the bladder wall inflammation disappears and the patient gets back the original capacity of the bladder. Or here, this is very challenging. At the beginning, we started with local instillation therapy at this patient, got some results, but was not enough. Then we repeated the cystoscopy and we could see some sign of annulation. Therefore, we made a hydrodistension and a coagulation, and after it, the patient became completely symptom-free for a longer time. Naturally, such visual demonstration of the condition of the patient helps us to define the treatment frequency. The initial treatment is generally weekly. Some authors recommend it for 12-15 weeks, but according to our experience, this means an overtreatment. Our maintenance therapy is a long-lasting, sometimes lifelong treatment, beginning with a 6-week installation, and when the patient proves to be in a good, stable condition, then we prolong it up to 12 to 14 weeks. So it is individually tailored continuous monitoring. A reasonable reduction of installation frequency based on this continuous monitoring reduces the treatment expenses. Some considerations. A local intravesical installation is the most effective treatment option. The bladder installation needs to be performed by using a urethral catheterization, as this method is nowadays generally accepted. But 70% of the IC patients also have urethral pain and the hypersensitivity in the urethra beside the bladder symptoms. Therefore, many patients refuse the instillation therapy, being afraid of the pain caused by the urethral catheterization. Is urethral catheterization really mandatory? This question rises. But we think no. This is not, because there is, in the last years, available an option, the so-called catheter-free bladder instillation, where we use a minimally invasive device, this tiny adapter, syringe adapter, which fits very nice on any Luer lock or Luer slip syringe. And just the tip, the reduced short tip, gets into the orifice of the urethra, and the collar, the isolating collar, lets fill the liquid slowly through the urethra into the bladder without any mechanical damage of the urethra. Here you see the flexible collar in the middle of the picture. On the left, how we use it in female patients, and on the right side, we use it in the similar way, in the same way, the same adapter in male patients as well. In the last 5 years, we have an experience of more than 3,500 installations, and we can state that there's no need of catheterization for a bladder installation. There's no mechanical lesion of the urethral mucosa. It's completely pain-free, quick, simple procedure in both the genders, and the simultaneous treatment of the bladder and the urethral mucosa is also an option, and we can say the only option to treat at the same time the urethra and the bladder. There remains some difficulties of the instillation therapy. It is very costly due to the drugs, which are expensive, due to the travel costs, as many patients are traveling from many hundred kilometers to get the treatment. It's time consuming. The patients need to set free maybe the whole day, and time is money. The medical care is also not very expensive, you know. Therefore, over and under treatment is also possible, which all rises the expenses. And the question of how the growing number of diagnosed IC patients and the high costs of long-term maintenance therapy make it inevitable to change the paradigm. Regular self-installation of the bladder is already an advantageous solution for the patients, but the proper identification of the urethral orifice can be difficult, and the handling of the syringe is also a challenge. To solve this, we developed a small assistive device for self-installation of female IC patients. At the same time, at this equipment, we also use the advantage of the adapter, which I showed you previously. Here in the picture, you see the equipment with the adapter and the tiny video camera, which looks at the tip of the adapter. We performed a clinical pilot study with this device in 15 patients. All patients learned to use the device properly. There were no injury, infection, or any other complication. All patients declared to keep on using this device also further on, and all patients would recommend it to use to other patients. Now, we went on, and now we have around 60 patients who use this device regularly at home. It has a lot of advantages. It can be used by a single hand, and the second hand remains for opening the orifice, as you see it on the right upper picture. There is no need of catheterization, so it doesn't cause any mechanical injury. There is a very clear visualization of the orifice from very close view. It's completely pain-free. It can make the treatment frequency tailored by the individual need, and it highly reduces the expenses. On the right-hand picture, top picture, you see how it can be taken with one hand, and there you also see the display where the tip of the adapter can be seen, and this helps to direct it into the orifice. The take-home message is that a personally optimized cocktail given in individually tailored frequency and dosage as a self-instillation improves efficacy of the treatment and minimizes the treatment expenses enormously. Therefore, this method should be considered as the future of IC-BPS maintenance therapy. Thank you for your interest.
Thank you very much, Dr. Lovász, for this very interesting and thorough lecture, and also congratulations for this, well, at least interesting idea about self-instillation. I mean, of course, in a pandemic like we have today, it might be a game changer when a patient don't have to go to seek an institute, but can have treatment at home. So yeah, that's definitely a good idea, and we have interesting ideas about all the practical aspects you mentioned. We have some questions about adding different things and your experience to the cocktails. A few participants asking about what is your experience about adding hydrocortisone in the mix or cortisone? Do you think it would be beneficial?
We tried different cocktails and different compounds. We have also experience with steroids. It can be hydrocortisone or methylprednisolone. The methylprednisolone proved to be a little bit more effective, but it was not a clinical trial, so I can just report on my personal experience, although I have to say within the last years, I treat regularly over 360 patients. So in the feedback, all these patients have these graphic feedback for us. So it is quite objective to say methylprednisolone is maybe more effective.
Yeah. And what is in your experience about all these combinations? What is the most effective combination or cocktail? I also had the same question to Dr. Janssen. What is your experience?
I think Dick answered already. We also always use combination, as I told. First, we tried hyaluronic acid alone, and then heparin alone. And the monotherapy, the response rate was low. Now we use always combination of hyaluronic acid and chondroitin sulfate. And sometimes we also add heparin to it. I have to mention that there's an option if somebody would like to use our adapter. It cannot be bought as a separate product in Europe, but there is a compound, a solution containing hyaluronic acid plus chondroitin sulfate. And with this solution in the box, it is packed together our adapter. So if somebody would like to use our adapter, then they can buy it with this solution together. And the results are very good. I have to mention that You know, the COVID problem. Patients cannot go to the doctor, they need the installation, etc. All those patients who are using the self-installation at home with this device, they don't feel any disadvantage of the COVID because they can use it at home and they get the pre-filled syringe from the pharmacy delivered per post. So this is maybe in COVID era the optimal.